Detection and identification of antibodies in the blood bank. We perform an antibody screen to detect irregular or unexpected antibodies in a patient's plasma. The antibodies of primary importance are the immune alloantibodies, which are produced in response to foreign red blood cells exposure through transfusion, transplantation, or pregnancy. Naturally occurring antibodies may form as a result of exposure to environmental sources such as pollen, fungus, or bacteria that may have similar structures to red blood cell antigens. A person may passively acquire antibodies that are produced by one individual and then transmitted to another via plasma containing blood product components or derivatives such as intravenous immune globulin. Clinically significant antibodies are those that cause decreased survival of red blood cells. These antibodies are usually IgG, react at 37, or AHG phase of the indirect antiglobulin test. An autoantibody is one that will react with the patient's own red blood cells. An autocontrol can detect an autoantibody. This is where we add the patient's cells and the patient's plasma together in a tube. The AABB requires the use of an antibody screen to detect clinically significant antibodies in the blood donor and the intended recipient. An antibody screen is included in the standard prenatal testing to evaluate the risk of HDFN in the fetus and to assess the mother's candidacy for Rh immune globulin prophylaxis. The tube method is the traditional method of detecting antibodies. It is the gold standard. An indirect antiglobulin test performed in the test tube. The serum or plasma is mixed with red blood cells called screening cells, which have known antigens on them. The phases of testing may include the immediate spin, which is now not required, the 37-degree Celsius incubation, where enhancement media is added to increase the sensitization. Depending on the enhancement added, the tubes may be centrifuged and observed for hemolysis and agglutination following incubation. The anti-human globulin phase is after 3 washes have been completed. If the test is negative, check cells must be added. The check cells must show a positive reaction or the testing is invalid. The screening cells and antibody panel cells are all group O. Screens can be either 2 or 3 cells in a set. Each set of screen cells is accompanied by an antigen profile sheet detailing which antigens are present in each vial of cells. The reagent cells will either be homozygous for an antigen or heterozygous for the antigens in a blood group. Antibodies that react more strongly with cells having homozygous antigen expression are said to show dosage. Enhancement media is usually added before the 37 degrees Celsius incubation phase to increase the sensitivity of the test system. These include 22% albumin, low ionic strength saline, and polyethylene glycol. The anti-human globulin reagents are either monospecific AHG or polyspecific AHG. The AABB standards sets requirements for antibody detection. Check cells must be added to all negative AHG results and it must be positive or the test is invalid. Antibody screens can be performed by gel method, which utilizes a microtubule filled with a dextrin acrylamide gel. The screen cells used for this technique meet the same criteria as the tube test, but are suspended in lists to a concentration of 0.08%. The reaction chamber is on the top of the card, above the gel. A positive reaction, the sensitized cells will be trapped at the top because of the lattice formation preventing it from dropping to the bottom through the gel. A negative reaction will drop to the bottom when centrifuged. The Immucore Capture R automated method is a solid phase adherence method. The cells are coated in anti-human globulin. If the screen cells become coated with patient antibody, the complex will stick to the bottom of the reaction chamber, as shown in the positive reaction below. If the cells do not become coated in antibodies, then the screen cells will form a button at the bottom. Be very careful to think about what a positive looks like, since we tend to think of a dot of cells being a clump and being positive in the tube method. When you are new at this, think about what positive and negative looks like, and then read and record the results. If there is agglutination or hemolysis at any stage of testing, it is considered a positive result. You must record the phase of testing that the reaction occurred in. You want to determine if the autocontrol is positive or negative. It should be negative. Did more than one screen cell react with the sample? Did they have the same strength and phase of reaction? Is hemolysis or mixed field agglutination present? Make sure to be able to differentiate true agglutination from rouleau. There are limitations to an antibody screen. First, if there is not sufficient antibody in the sample, it may not be detectable. If a person has an antibody to a low prevalence antigen, most panel cells and screen cells will not detect them. Sometimes, if the antigen is not expressed well, the reactivity with the antibody may not be detected. The cell to serum ratio should be a 1 drop of reagent red cells and 2 drops of patient plasma. If a kit antibody is suspected and is weak, it may require 4 drops of plasma. The length of incubation should follow the package insert for the enhancement media used. The pH of the reagents must be correct, or the reaction may not occur. If an antibody screen is positive, then additional testing is required to identify the antibody. So instead of 3 screen cells, you will test 11. This is an antibody panel. It is important to check the patient history to determine if there is prior history of an antibody. Even if there is history of an antibody, you must determine if the patient has developed additional antibodies. The reagents for an antibody panel are 11 vials of group O red blood cells with various antigen expression. There must be a diverse pattern of antigen expression of the cells. Each vial is diluted cells with donors who are paid for their donations. Many cells must have homozygous expression of the antigens. Heterozygous expression is not as valuable, but you will have some antigens that are heterozygous while others are homozygous. Antibody identification is done by excluding the antibodies that could not be responsible for the reactivity. This is called rule out. Mainly, the cells used for rule outs should be homozygous, although heterozygous cells are permitted for some antigens. Each facility will have procedures and requirements for how to perform rule outs. To perform rule outs, we will use the cells that have not reacted with the patient's plasma. In class, we will highlight the rows that have no reactivity at the 37 and AHG phases of testing. This will help us from accidentally ruling out the wrong cells. Once you have done rule outs on the negative cells, you should look at the pattern of reactivity to see if there is a pattern of antigen positive cells that could be responsible for all of the positive reactions. This is called inclusion. If you think there is an anti-D, then all of the D positive cells should be positive and the D negative cells should be negative. If you think the anti-D is an issue and a D negative cell is also reacting with the plasma, then this would mean there are multiple antibodies that are present. You should examine which phases and strengths of reactivity is found. If you have multiple phases and different strengths of reactivity, then multiple antibodies should be suspected. When reviewing your results, ask, do all of the positive cells react at the same phase of testing? If reactivity occurs at immediate spin for some cells and AHG for other cells, you would suspect a cold reacting antibody and a warm reacting antibody. Next, does the reactivity match any of the remaining specificities that have not been ruled out? Have all commonly encountered antibodies been excluded? Is there an auto control that is positive or negative? Once we have done our rule outs, we must do our inclusion. We must have sufficient evidence to prove that the suspected antibody is present. If we do an antigen type on the patient, they should lack the antigen corresponding to the suspected antibody when the autocontrol is negative. We must then apply the 3 and 3 rule. There must be 3 antigen positive cells that react with the patient's plasma, and there must be 3 cells lacking the antigen that do not react. This will give us a 95% confidence that the antibody that is reacting with the screening or panel cells is to the suspected antigen. A patient's phenotype may be complicated when a patient has a positive DAT or when the patient has been transfused in the past 3 months. If a patient has a positive DAT, you will want to use chloroquine diphosphate or acid glycine EDTA to remove the antibodies on the cells. This will leave the red cell membrane intact and allow you to do the antigen type of the cells. If the antibody coating the cells resists elution, an absorption method may be used. If a person has been transfused, this is not helpful since some of the cells are not the patient's. A genetic test may be required. Select cell panels. Once we have completed a single panel and have performed a rule out as well as an inclusion, we may still have antibodies that have not been ruled out or in. We must select cells to perform additional testing on to determine if any additional antibodies are present. The requirement for select cells are as follows. The cells must be negative for the antigen corresponding to the antibody that we have 95% confidence is present. The cell must be homozygous positive for the antigen we still need to rule out. The cells may be heterozygous for this antigen if it is a low incidence antigen. When there are multiple antibodies and you don't have enough negative cells to do rule outs on them, you can use an enzyme treated panel because some antibodies will react with these while others will not. Remember, when you use an enzyme treated panel, you cannot rule out Duffy A, anti-Duffy B, anti-M or anti-N, anti-big S or anti-little s. But by comparing the reactivity of the two panels, this can help you see the multiple antibodies more clearly. Some of the enzymes include physin, papain, bromelain, or trypsin. These enzymes modify the red cell surface by removing sialic acid residues and by denaturing or removing glycoproteins. The enzymes will destroy certain antigens while enhancing the expression of others. Neutralization works by introducing a substance that will bind to certain antibodies while leaving others behind. The P substance in hydatid cis fluid is an example of neutralization. If a sample is reactive prior to neutralization and negative after neutralization, this tells you that the specific antibody is present. For instance, if you add hydatid cis fluid to a sample with anti-P1 antibody, you will get negative reactivity with P1 cells. If you suspect that you have multiple antibodies, you could use absorption techniques to help. You can mix the plasma with cells that are positive for one of the possible antibodies and negative for the other. The antibodies will attach to the cells and leave only one antibody in the plasma. If a person makes an antibody against their own cells, you could use the patient's cells to absorb the antibody and autoabsorption. Then you could test the plasma to see if there are alloantibodies that are also present. A homologous absorption is when you use cells that have the same antigens as the patient instead of the patient's, sort of a mock autoabsorption. This is done when the patient can't afford to give up any blood to perform an autoabsorption. A differential absorption is when you use different cells to pull one antibody out so you can see the other ones. Say we have an anti-little e and an anti-Duffy A, we could absorb out the anti-little e with cells that are little e positive and Duffy A negative, and absorb out the anti-Duffy A by using little e negative and Duffy A positive cells. Then you could test both of these absorbed plasmas to identify the antibodies separately. The direct antiglobulin test, or DAT, is used to investigate hemolytic transfusion reactions, hemolytic disease of the fetus and newborn, and autoimmune and drug-induced hemolytic anemias. The test detects in vivo sensitization of red blood cells. The process can be accomplished via tube method, solid phase, or gel technique. If IgG antibody is detected on the surface of the patient red blood cells, we can dissociate the antibody from the cell via several elution methods. We can use temperature, pH adjustment, or organic solvents. There are now elution test kits available commercially, and the manufacturer's instructions should be followed. An antibody titer can tell us the amount of antibody that is present, and if we perform this test over time, we can see if the amount of antibody is increasing, decreasing, or remaining the same. We usually do this via a serial dilution of serum tested against red blood cells that possess the targeted antigen. We determine the titer level as the last tube with 1+ or greater reactivity. If there is a 4-fold or greater increase in titer or an increase in score of 10 or more, this is a significant change. A 4-fold or greater increase is if you increase by 2 tubes in the serial dilution. And you can see that if you look at the score of a titer, anything that's 4+ is worth 12 points, 3+ is worth 10 points, 2+ is worth 8, and 1+ is worth 5. So you could score it the first time and then the next time, and then you could see what the difference is. There are several clinical applications of antibody titration in the blood bank. We use this to evaluate the risk of hemolytic disease of the fetus and newborn, to differentiate immune anti-D from passively acquired anti-D due to program administration, and to confirm the presence of antibodies previously known as HTLA antibodies, or high titer, low avidity. These are usually antibodies to high prevalence antigens that react weakly but have a very high titer. When an antibody is present, you must test the donor cells for the antigen, and they must be negative before you can cross-match the units. You will consider the frequency of the antigen in the population and the clinical significance of the antibody. This can tell you how many units you will need to test to find the number of units that you need. Donor centers routinely perform antigen typing for Rh antigens on type O donors. Then they have this information in their database and can quickly find antigen negative units for you. So usually the blood bank can call the donor center to order antigen negative units. If a patient has a clinically significant antibody, or they have had a past history of a clinically significant antibody, units selected for transfusion must be negative for the corresponding antigen. When a person has a clinically significant antibody, a computer crossmatch is not allowed. A crossmatch demonstrating compatibility at the AHG phase is required. To calculate the number of units to antigen type to fill the crossmatch requirements, divide the number of units required by the frequency of the antigen negative individuals. For example, if we require 2 units and the antibody is anti-E, where the frequency of E negative units is 0.70, we divide 2 by 0.70 and we get 2.8. But we round that up to the whole number because we can't test 0.8 units. So to find 2 compatible units, we must test 3 units. It is generally proposed that for certain population, those that require multiple transfusions throughout their lives, is that they should receive phenotypically matched cells to avoid formation of alloantibodies. These are people with beta thalassemia and sickle cell disease. Thank you for listening.